Good afternoon, everyone, and welcome to a very special Topical Thursday this afternoon. It's my pleasure to introduce our special guest, Clinical Associate Professor Martin Krause, who will speak to us about the importance of secondary prevention of stroke. Martin was born and educated in Germany, and he studied medicine at Heidelberg University and completed his postgraduate medical degree in 1995. He undertook his doctoral thesis in radiology, investigating the diagnostic accuracy of digital picture archiving and communication systems, which he completed in 1997. After an internship in surgery, haematology and rehabilitation, Martin was offered a training position in neurology at the University Hospital in Heidelberg in 1997. Working under the mentorship of Professor Werner Hacke, a world leader in acute stroke treatment, Martin was inspired to find new ways of treating stroke patients. Further experience came in the Heidelberg neurocritical care unit, stroke unit and emergency department before undergoing training in neurophysiology, where he received formal qualifications as a neurophysiologist by the German Society of Clinical Neurophysiology and training in vascular neuro-sonology. In 2006, Martin moved to Australia after being offered a medical academic position at Nepean Clinical School before being appointed Neuroscience and Stroke Network Director in the Northern Sydney Local Health District in 2011, a role he still holds today. In 2015, he was appointed Head of Neurology Department in Royal North Shore Hospital. Martin teaches a masterclass and lectures in neurology for Stage 2 medical students and young doctors at the University of Sydney's Medical School. He remains involved in stroke and movement disorder research and is a member of the Stroke Society of Australasia. Martin has authored over 60 peer-reviewed scientific publications. It's a real joy to have Martin with us this afternoon, as his knowledge is extensive. He's supported the association over many years, particularly at our conferences. So welcome, Martin.
Thank you very much, Michelle, and thank you for this kind introduction. So this is, first I want to show you a little video of a German Coast Guard on his first day on the survival radar. So have a listen to it, and it's partially German, partially English.
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät, das Gefäß. Das ist das Überlebensradar. Mayday. Hello, can you hear us? Can you hear us? Can you? Over. We are sinking. We are sinking. Hello? This is the German Coast Guard. We are sinking. We're sinking. What are you thinking about?
So if you feel like this, that British sailor in my talk, please ask questions, send me a chat, or give us information back. I'm happy to interrupt and talk to every topic, or we can collect questions later and ask them. So stroke is a real success story in Australia, and over the last 32 years, stroke mortality, so deaths related to stroke, has declined by 70% within Australia, and that is absolutely amazing. This is equal in most other countries, but it's one of the best achievements around the world. If you look at stroke mortality was one of the most common causes of death in Australia 30 years ago. Now it's the third or fourth most common cause of death after coronary heart disease, dementia, which is one of the more common causes of death nowadays, and lung cancer in males. And that reflects that we are very successful in preventing strokes. If you look at a global scale, there's a tenfold difference between stroke mortality. Those countries here in dark red have a tenfold higher stroke mortality than those countries here in yellow, which indicates that we have a very low stroke mortality. The best predictor for stroke mortality is per capita income and what you spend in healthcare, which is really fabulous. And while we saw a decline in stroke mortality throughout all socioeconomic classes, there is still this gap between the rich and the middle and low income earners. And I think I'm a socialist by heart, and I feel we really need to change that, and we need to close that gap between rich and poor people. Healthcare cannot be dependent on how wealthy you are or what financial resources you have. Now, today I want to talk what is a stroke. I want to talk about what are important stroke measures to prevent strokes from happening, because preventing a stroke is so much better than treating a stroke. And I want to talk also about a few new diagnostic tools we have to investigate people with a stroke. And lastly, I want to talk about things that I feel have very little value but might cost you a lot of money. So what is a stroke? The vast majority of strokes is an infarct, where a vessel in the brain is occluded and the brain doesn't get enough oxygen and blood and dies as a result of that. And the vast majority of strokes are due to clots that form outside of the skull, either in the heart or in the large arteries, and then travel up to the brain and cause a stroke within the brain. There are also small little arteries in the brain, or capillaries, that can occlude, and they can cause also strokes. We call them lacunar strokes. They often go unnoticed, but in totality, they might lead to cognitive decline or balance disorders, and therefore they often are less noticeable unless you have lots of them, and then you notice them, but then it's too late to do something about it. There's an interesting shift in the large strokes from the large artery strokes, so clots in the carotid arteries and plaques there, to more cardioembolic strokes. So while large artery strokes was very, very common in the beginning of the 21st century, 10 years later, they are much less common. We don't see carotid plaques that much anymore, whereas we see a lot more cardioembolic strokes. And there are two reasons for that. One is that people live healthier. They stopped smoking. We have much less smokers than we had 20 years ago. And that has reduced these plaques in these arteries. And we use statin therapy. So statins are cholesterol-lowering medication that reduce plaque, shrink plaque, and stabilize plaques. We don't see plaque ruptures on these medications anymore. And we have better technology to find clots in the heart, and that made it easier to detect clots that lead to strokes from the heart. There are also bleeds in the brain, and bleeds are much less common than ischemic strokes. And there are different types of bleed in the skull. One is a bleed directly in the brain, which is called intracerebral hemorrhage. Or if the bleed is outside of the brain, it's either a subarachnoid or subdural hemorrhage, or an epidural hemorrhage, which is often a traumatic injury and can lead also to devastating consequences. If you look at overall ischemic strokes, so the infarct in the brain is 80% of all strokes. So I'll talk largely about ischemic stroke, but whatever is true for ischemic stroke is often true also for intracerebral hemorrhage, which is around 12% of all strokes. And the rest of these strokes are much less common types of stroke, and I won't talk about these in specific ones. The one thing that makes the biggest difference overall is lifestyle. And I want to focus on lifestyle, but I'll also talk about some medication, which I feel are great important contributor to the reduced stroke rate and reduced stroke mortality. Now, these are the most common risk factors for stroke. And the few gray ones here on the top are the ones which we can't change, even though sometimes we would like to be younger or have different relatives. But the age is the most important risk factor. Every 10 years, we double our stroke risk. We start off with a very small stroke risk, and if you double a small stroke risk, it's still a small stroke risk. But if you double that often enough, then your stroke risk is quite high. So if you're in your late 80s or 90s, your stroke risk is by age already quite high. If you're male or have a first-degree relative with a stroke, then you also have a double stroke risk compared to those who don't have a first-degree relative with a stroke. Now, these things we can't change, but what we can change are the ones here in red below that. And the light red ones are the ones which I think are really, really important, and these are things I would encourage you. If you do only two things, I would treat hypertension, high blood pressure. If you treat and normalize blood pressure, you prevent 70% of all vascular events. 70%. That is huge. And if you live a sedentary lifestyle, you triple your stroke risk. And this is things you can really change. So let's talk about these risk factors and what we can do about it. Now, hypertension, high blood pressure. Don't know why the screen doesn't show it. Do you see the hypertension screen?
Yes, we do, Martin.
Okay,
yes.
Because it doesn't come up in my GoToMeeting. So hypertension is really, really common. If you look at the over 65-year-old population, then more than 2/3 have high blood pressure. So hypertension is so common that people actually don't really know what normal blood pressure is so often anymore. So I have a little quiz here. I just want to tell you why hypertension is so important. If you look at systolic and diastolic blood pressure, they correlate linear to stroke. If a hemorrhagic stroke, this correlation is fairly steep. And for ischemic stroke, it's a little bit flatter, but still, the higher your blood pressure, the higher stroke risk. The lower your blood pressure, the lower your stroke risk, meaning there is no optimal blood pressure. There's only too high blood pressure. And from that perspective, you would really like to normalize blood pressure as much as possible. Now, I added a quiz question. I don't know how we can do this, but maybe Rachel and Michelle can help me here with that. So I want to know from you, what is normal blood pressure? So A, under systolic, under 110 and under 70, or B, under 120 over 80, or C, under 130 over 85, or D, under 140 over 90. Can we get a show of hands or maybe some text? Can someone text me what the answers is? What do you think?
We might get people to do 1 finger for A, 2 for B, 3 for C, and 4 for D. Does that sound all right?
That sounds great. I can't see the people, unfortunately.
Now
I can see. Oh, yeah. Okay, now I see them. Excellent.
Okay.
Under 120 over 80. Oh, I don't need to talk anymore. You're real good. Fabulous. So this is the American Heart and American Stroke Society guideline 2017 on hypertension. And that outlines what is normal blood pressure. So most people think that, under 120 would be a low blood pressure. But if you measure the blood pressure in, normal young healthy adults, like in recruits in their 20s, their systolic blood pressure normally sits around the 100 mark. This is perfectly bang on middle normal. So between 100 and 120 systolic is normal. Under 80 is normal. This is normal blood pressure. If your systolic blood pressure sits between 120 and 129, it is already elevated. If your blood pressure is over 130, your systolic blood pressure, or your diastolic blood pressure over 80, then you have stage 1 hypertension. If your blood pressure is over 140 or your diastolic blood pressure over 90 or both, then you have stage 2 hypertension. If your blood pressure is over 180 systolic or your diastolic value over 120, then you have a hypertensive crisis. This is a medical emergency. This is something that you need to come to an emergency department to get treated. So this is really important. If you can normalize your blood pressure, you can prevent 70% of all strokes. And for that, you need to do lifestyle and medication. Now, the diet that has the best effect on blood pressure was the so-called DASH diet, was a dietary approach to hypertension. This diet actually, created different diet composites and found out what are the best components in diet that reduce blood pressure, the risk of stroke and heart disease and vascular disease. So the one thing that stood out in every study was that sodium is bad. If you have a lot of salt, your blood pressure is high. If your salt is low, then your blood pressure is better. So avoid salt, and that is part of the DASH diet, but also eat largely plant-based food. So grains, fresh fruits, vegetables, legumes, nuts, seeds. These are things that reduce your stroke risk. Low-fat dairy products you can have, but not more than 2 to 3 serves per week. You can have lean protein, and we need protein because plants don't have all the essential amino acids. So it helps to eat lean meat. But if you want to eat meat, don't eat a lot, and don't eat red meat because it has a lot of saturated fats. There was one study that looked at the long-term effects of diet in regard to stroke risk. That was the Mediterranean diet stroke incidence study that looked at female teachers in California and followed them, I think, for 20 years and looked at their stroke risk and had a self-reported adherence to the so-called Mediterranean diet score. Now, the Mediterranean diet score was based on what people in Corsica ate in 1920. So it was a long time ago, 100 years ago, and it was the Mediterranean. The study in the 20s, in the previous century, identified that people in Corsica lived longer than people in the US. And they looked at why is that the case. And they were very poor people there. They grew their own vegetables. They didn't have much money to buy meat or alcohol or other things. They worked a lot physically, and they lived longer. And that defined that score. So you get a lot of good points for cereals, whole grain bread, whole grain pasta, brown rice, vegetables, fruit, some dairy products, some fish, poultry. You get no points for red meat. And if you adhere to that diet, then your stroke risk is lower. But I want to make the point that what we understand nowadays of Mediterranean diet has nothing to do with this Mediterranean diet score. So if you look at what you can get nowadays in Mediterranean countries like pizza or this French recipe, I'm not sure, do you see the pictures of the food there? This is all pictures from French, Italian, Spanish food. Has nothing to do with what we consider Mediterranean diet. So you adhere to these old Mediterranean diets, so largely vegetables and fruits and grains and legumes, then you reduce your risk of stroke by about 17%, which is good, but it's not huge. So diet makes a big difference. And the biggest bang for the buck is the salt reduction and having a lot of vegetables in there. Now, the second most important risk modifier is actually physical activity. And there's a lot of different rumors on what is physical activity. So one myth I want to bust is house chores are no physical activity. If you do house chores, it doesn't count to your physical activity daily count. So aerobic exercise is defined by what we call metabolic equivalent time units. So if you sit, then you have one metabolic equivalent time unit. To reach moderate physical activity, you need to triple that up to 6 times, then you are in moderate physical activity. To reach high intensity physical activity, you need to more than 6-fold increase that. So just to tell you what moderate physical activity is, you need to walk very briskly, 6 kilometers an hour. Now, if you're on a treadmill, try to walk 6 kilometers an hour. That's pretty tough. That's not easy. If you can talk with 6 kilometers an hour, you're really fit. As a rule of thumb, to reach moderate physical activity, you must be so breathless that you can't talk anymore. You can just say, yes, no, otherwise you're not really you're not doing physical activity. So my question for you now is, how much moderate physical activity should you do per week? So less than 2 hours, 2 to 4 hours, or more than 4 hours. Show of hands. 1 finger for A, 2 fingers for B, and 3 fingers for C. So we see a few C's, we see a few B's, and we see no one with A. So that's good. That's good. So let's have a look at what the World Health Organization says. So the World Health Organization says there's a dose efficacy relationship of physical activity to risk of stroke and other diseases. So the more you do, the less your risk of stroke and heart disease is. And to get a real good reduction in your stroke risk, you have to do at least 300 minutes of moderate intensity aerobic physical activity per week. 300 minutes, that's 5 hours. And that is, 1 hour playing tennis per day. 1 hour walking with 6 kilometers an hour per day for 5 days a week. Or if you go to the high intensity exercise, which means you run 9 kilometers an hour, 9 kilometers an hour is a pretty tough, good speed to run. You know, even young people, not many young people are capable of doing this for an hour. Then you only need to do half. If you do low intensity exercise, you need to do 600 minutes, 10 hours a week to do that. And you should also do 2 hours of strengthening exercise per week, which means it increases your strength, your coordination, and your bone density. So actually, you should do 1 hour per day of really good exercise, 1 hour per day of really good exercise. And you not only live a lot longer, you have less stroke and heart disease, less cancer, and less mental health issues like depression or anxiety. You also look a lot better, as you can see. So let's talk about stroke risk and cholesterol. Now, cholesterol is really common in the Australian population, as you can see here in this graph. About half of the Australian population throughout all ages have high cholesterol, and that obviously has something to do with what you eat. The good old Australian barbie is not a very healthy food, although very delicious. I enjoy my barbie as well. But red meat has a lot of saturated fat, and that contributes to high cholesterol. And obviously, it also genetic predisposition increases cholesterol. So about 75 to 80% is actually genes, only 20 to 25% is diet. And there was this really interesting piece in ABC television a few years back, and I want to play that because it had such an impact on people, and I hope you can hear it. So.
We've been led to believe that saturated fat and cholesterol cause heart disease. Maybe cholesterol is not the enemy we think it is, but have we all been conned?
It's been touted as the biggest myth in medical history.
In a two-part special, Catalyst investigates the science behind the claim. That's not science, that's marketing. And gets to the heart of the matter. Here's the part that nobody talks about. Catalyst, Thursday at 8 on ABC1.
So I hope you could hear that. I'm not sure who saw that at the time. It was 1 million people who watched it, or nearly 1 million people in Australia who watched it. And it was quite amazing because we had so many people who presented to us afterwards with strokes due to stopping all the medication, which was terrible. And I just wanted to, to drill into the science behind lowering cholesterol. So there will be the cholesterol lowering drugs like statins are one of the best investigated drugs overall. This is a summary from a publication in Lancet in 2012 that summarized 22 randomized controlled trials, which had a total of 134,000 patients with an average follow-up of 5 years, comparing statins to placebo. Placebo is a tablet which doesn't contain anything. So basically statins to nothing in people who had a vascular event. And no matter whether you looked at stroke, heart disease, peripheral vascular disease, no matter how high your cholesterol was, whether it was low or high, no matter how high your risk was for stroke or not stroke, you benefited from statin therapy. And the benefit was huge, was 25% roughly risk reduction. That's twice as much as you get out of aspirin, in a risk reduction perspective. And the point was, it didn't matter whether your cholesterol was normal when you had your stroke or heart attack. You still had a benefit from statin therapy. And the editorial that was written in Lancet in 2012 to this article, where it was published, had the catchy title, Statins for Everyone by the Age of 50, which is actually quite an interesting hypothesis to think about. So statins really hugely reduce the risk of stroke and heart disease. And with the event of statin, the plaque ruptures and the big plaques in large arteries have largely disappeared. So statin therapy are hugely beneficial. If you look at the benefits of statin therapy, if you treat 10,000 people with a statin over 5 years who had a vascular event, you prevent 1,000 strokes and heart disease, heart attacks within these 5 years. And you have only 50 out of the 10,000 people who have minor side effects. 49 of them have very minor side effects which will not stop the statin, like gastrointestinal upset or mild liver function abnormalities. Only 1 out of 10,000 will have a side effect that will stop the statin. So 1 person against 1,000 who don't have a stroke or heart disease, that's a huge benefit to risk ratio. And so from that perspective, this piece in ABC is so hard to understand why they aired it. And obviously, you know, there was a lot of criticism from all scientific societies about that piece. Let me talk about atrial fibrillation. Atrial fibrillation is not common, but if you have it, it's a huge stroke risk. And there have been a few new developments in atrial fibrillation. I want to talk about them because I think they're really exciting. So in atrial fibrillation, the heart doesn't contract well anymore. So the atrium, which is this part of the heart, the top part, flutters or fibrillates. And if it doesn't contract well, blood stays too long in that part of the heart. And in this case, blood starts clotting. It's the same in the legs. You know, if you're on a long distance flight, the blood doesn't circulate in the legs, you get clots in your legs, and that's called DVT or deep vein thrombosis. In the heart, it's a clot in the atrium. And because the brain takes 1/3 of the whole blood circulation, it has a 1 in 3 chance to end up in the brain and causing a stroke. And these strokes are pretty bad strokes. Atrial fibrillation is not common, but it becomes more common as we grow older. But it becomes a really huge risk factor if you have other risk factors. And we can detect atrial fibrillation by different means. You can get a Holter monitor. This is here in the top, you know, where you put these electrodes on. It's like an ECG, and you record it for 24 or 48 hours. These Holter monitors now can record up to a week, you know, of your heart rhythm. And the longer you monitor, the more you find people who have intermittent atrial fibrillation. Or you can implant a loop recorder, which unfortunately is not funded by Medicare at the moment, which makes it a very costly kind of intervention. But it can stay in your body for 3 years and can record your heart rhythm for 3 years and detect whether you have atrial fibrillation in that part as well. So that really helps us to identify people with atrial fibrillation. And if you have atrial fibrillation and nothing else, then obviously you don't need to treat that. But if you have any of these risk factors, then you need treatment. So if you're over 65 and have atrial fibrillation, you get 1 point. If you're female, you get 1 point. If you had a TIA and stroke, you get 2 points. If you have heart failure, you get 1 point. And if you look at the risk, only those who have a CHETS-VAT score, that was the risk score of 0, have a 0.2% of having a stroke per year. If you have 1 point, your annual stroke risk is 0.6%. And if you have 2 points, your risk is 1 in 50. If you have 6 points, your risk is 1 in 10 per year. And that is a huge risk. That's a huge risk of having a stroke. And these strokes are big strokes. They're devastating strokes. So these are people who often do not walk after their stroke anymore, who are bed-bound or wheelchair-bound in a nursing home. So atrial fibrillation is a really important risk factor. It's not common, but if you have it, it is something you need to treat. And the best treatment for it is anticoagulation, so AC here. And this is a study which looked at anticoagulation with warfarin. Aspirin really doesn't change that stroke risk. And if you compare, warfarin reduces the risk of stroke in atrial fibrillation by roughly 60 to 70%, whereas aspirin hardly changes that risk at all. Now, warfarin has always been a real problem, as you know. Warfarin was really difficult to get right. The warfarin was always measured in the International Standardized Ratio, or INR. And if the warfarin was too high, the INR was too high, you had a bleeding risk, bleeding in the brain or bleeding somewhere else. If the warfarin was too low, you had a stroke risk, you were not protected. And the problem with warfarin is that warfarin works as a vitamin K antagonist. So it blocks the vitamin K uptake in the bloodstream. And warfarin is important. The vitamin K is essential to build certain clotting factors in the liver. If the liver doesn't have enough vitamin K, it can't form functioning clotting factors. And that's the way warfarin works. The problem is that if you drink alcohol, which has an effect on the liver, then it made it very, very difficult to get the warfarin right. Or if you ate one day all broccoli, which has a lot of vitamin K, and the next 5 days nothing, then it was really, really difficult to get the warfarin right. So that has changed now with new drugs, dabigatran, rivaroxaban, and apixaban, which work differently. They actually block these clotting factors, and with that, they block the whole clotting cascade. If you block these clotting factors, the body cannot form these clots, and therefore it stops the clot formation. And therefore, with these new drugs, it didn't matter what you eat. These drugs work, and they are the fixed dose relationship, which is really fantastic. You know, they act much less than warfarin. They work only for 12 to 13 hours. It's their half-life time. That's why you need to take them twice a day. And they rely heavily on kidney clearance. So all the drugs go either out through the liver or the kidneys in the body, and they largely go through the kidney. So your kidney function needs to be normal. But they have shown to be actually more successful than warfarin in preventing stroke and systemic embolism, and they have been shown to be hugely more safe than warfarin. So they had much less bleeding complication than warfarin. However, if you have a bleed on these anticoagulation drugs, like let's say you had a fall and have a subdural hematoma because you were on warfarin or one of these NOACs, then you need to stop the anticoagulation. And there's a new gadget that can actually prevent clot formation in the heart, and that's called the Watchman device. So the Watchman device is a little kind of, it looks a little bit like a jellyfish that's pushed into the appendix. The appendix is a little part of the atrium where most of the clots form. The appendix is one of those things in the heart which we don't necessarily need. It can contract when you exercise really hard and push more blood out into the heart, but in most cases we don't need it. And you can occlude this appendix with this device, and therefore most of the clots are gone. It's nearly as effective as warfarin, and you don't need to be on warfarin if you have this device to reduce your stroke risk. For those people who can't take the warfarin because they have a lot of falls, had previous bleeding complications, this might be a really interesting alternative and can be done to prevent the stroke risk. It's not as good as warfarin and NOACs, but it's nearly as good as warfarin. So that's the way how it doesn't require surgery. It's just, you know, introduced with a catheter into that part and stays there. So it's not a terribly complicated procedure. So I want to spend a bit of time on new diagnostic tools on how we identify people with stroke and what we can do in regard to treatment of stroke. So the common stay for diagnosing stroke is a CT scan. CT scans are available in nearly every hospital in Australia, and they can immediately identify if someone has an intracerebral hemorrhage, which is the white part here, or an ischemic stroke. Now, the ischemic stroke you can see here is a darker area, but this stroke is about 5 days old. So in the initial phase, we only see the bleeds really well. This is a CT scan from someone who had symptoms for 3 hours, and he's completely paralyzed on the right side and doesn't understand language and can't talk. And you would say this is a really big stroke, but it's really hard to see this stroke on the CT scan. The only thing you can see is this little white little worm-like structure here. And this is the clot in the middle cerebral artery. It's the biggest artery supplying the blood to the brain, and that is completely occluded. But the stroke itself is really hard to see after 3 hours in the CT scan. Even after 30 hours, it's not that easy to see. As you can see here, this is an area which is a little bit darker now. So it takes days until we see strokes really well in CT scans. So what can we do to make stroke CT better? So one thing is we can inject contrast. And with the contrast, we immediately see the vessels. This is the aortic arch, and these are the big arteries going to the brain. And this is the vessels in the brain. So we can see immediately if one of these major arteries is blocked, and that, you know, is done within minutes, you know, so we can see that. That's really helpful. So we can see all the brain arteries, as you can see here. We can see whether there's a clot sitting in these middle cerebral arteries, and that guides treatment and can help us differentiate. But we can do more than that. We can actually scan people after injecting contrast every second. And you can see that these 3 patients have exactly the same condition. They all have a large vessel occlusion. So there's a fat clot sitting here, breaking off this artery. Same in this case, and same in this case on the other side. So all of them has what we call an M1 occlusion of the middle cerebral artery. This is a bad stroke, really bad stroke. But the first patient here in the first row, you can see that the vessels on both sides of the brain look pretty good. This is 1 second out, 2 seconds, 3 seconds. And you can see they look pretty good. This is because this patient has really great collaterals. So collaterals are other vessels supplying blood to that part of the brain. And if someone has great collaterals, the brain has more time to survive and the stroke will be not as big. Whereas the last line here, this patient has very, very poor collaterals. You don't see many vessels on this side, and you can see the vessels come very, very late. So this patient will infarct really rapidly the part of the brain, and there's not much you can save if it doesn't happen really, really fast. And you can do even more. We can look how the passage of contrast goes through the brain. This is what we call a perfusion scan, and this technology was actually developed partially in Australia. So it's a really exciting technology, and it's a video which I want to show you, which I took from a screen grab. So if you just look at this part of the brain, you can see that there's an area here in the brain which doesn't change with the contrast going to the brain. So this is part of the brain which doesn't get any contrast. So there's no contrast flowing through this part of the brain. So I show you a slice further up in the brain. So now you can see here how the contrast goes through the brain. And you see first the vessels showing up in the brain. Then you see the change in the brain tissue. But there's this area here that doesn't change much in contrast. So we can measure these curves of contrast change or absorption of radiation in that part of the brain. And we can do, you get these arterial curves, how the contrast goes through the arteries. You can get here the green line, which is how the contrast changes the tissue in the brain. And then you see the venous curve, how the contrast flows out of the brain again. And then we can use some fancy mathematics and then color code it back into the CT scan. And that gives us a map where we can see what part of the brain is already dead, which we can't save, and what part of the brain is critically impaired in their blood flow and gets very, very little blood and will die if we can't restore the blood flow to the brain. And we can color code this. This is a perfusion map as we get it in lifetime when we investigate a stroke patient with this technique, and that shows this patient has a very large stroke, with a core volume of 140 mil nearly. That's about 2/3 of the brain on that one side. That is a really devastating stroke, and there's a little bit of tissue left we could save, but this patient will have a really terrible outcome, and there's not much we can do because it's too late to save brain. Now, time is really, really critical in a brain. So when a clot goes to the brain, occludes an artery, then you initially have only a very, very small part of the brain that relies only on this vessel and dies within minutes. But there's a much larger area in the brain that's at risk and will die over time. But time is really, really rapidly evolving this infarct. Within 90 minutes, there's a lot of brain you still can save. Within 4.5 hours, there might be a little bit of brain you can still save. Within 6 hours, there's often nothing you can save anymore. And Jeff Saver outlined how many nerve cells you lose in a stroke per minute. So per minute, you lose 2 million nerve cells in your brain. 2 million nerve cells, or 40 billion connections between nerve cells in the brain. You lose 12 kilometers of myelinated fibers in the brain. So these are nerve fibers, 12 kilometers per minute. All your brain ages by 3.1 weeks per minute in a brain, in a large vessel stroke. So time is just so incredibly critical in a stroke. So don't wait when you have symptoms of a stroke, like a weakness in one arm or speech disturbance or vision loss. Every minute counts, and you need to get to a major hospital to be treated. The best treatment we have is a clot-busting agent called Actilase, or tissue plasminogen activator. It's injected into the vein and can dissolve small clots and restore the blood flow to the brain. If you give this drug within 3 hours, you can double the number of people who live without disability. So this is the modified ranking scale. 0 means you have no symptoms. 1 means you have symptoms but no disability. So 0 and 1 is really what you want to achieve. No disability. You could say that a slight disability is still acceptable in some ways, so people, are still able to look after all their previous activities, or, they don't go back to work, but they are still living independently. So for a big stroke, you would say that's still a reasonable outcome. But ideally, you don't want to have any disability from it. And if you treat people within 3 hours, you can double that number. After 3 hours, the number is still successful, but not as effective anymore. And you can see with time, the benefit to risk ratio really changes dramatically. So within 90 minutes, the benefit to risk ratio is huge. After 4.5 hours, the risk to benefit ratio is not as big anymore. And after 6 hours, the risks probably outweigh the benefits. Now, if you have a very large clot, like in this patient, where the carotid artery here is cut off with a huge clot, thrombolysis will not do anything, because the thrombolytic therapy doesn't travel up into the part of the brain to reach the clot, because there's stasis in this vessel. And these patients have really devastating strokes. And this was a 89-year-old patient, who was really fit from home, living on his own. And he came into our hospital, and you can see he had very little core infarct. So the stroke wasn't established, but half of his brain would die if we couldn't restore the blood flow to this part of the brain. And thrombolysis would not really change that. The likelihood that these large arteries open up with thrombolysis is about 25%. So it's vast majority don't open up. So in recent times, there's new treatment that allows us to pull out really big clots, and that's really exciting. Again, Australia was on the forefront of developing this. With these so-called stent retrievers. So these are catheters which are pushed up through the arteries and then pushed through the clot. Then they pull back the sheath, and a stent expands, a normal stent, which looks like this, like a mesh. And then you pull the whole thing with suctioning back, and you can get huge clots out, like this one here. You can see this is a huge long clot, and they pull them out with one go, and that's amazing. You can restore the blood flow to this part of the brain in most patients quite successfully. So you can see this is our study here, the Extend IH study, which we ran in Australia, that if you treat people with this embolectomy, you really have a huge improvement in their outcome. Again, the modified ranking scale from 0 to 1 or 0 to 6, which shows that. It's incredibly successful, but again, time is really relevant, because every minute you waste, you lose 2 million neurons. Now, with this new technology, the perfusion scan, we identify more and more people who actually benefit from treatment even after the 4.5-hour time mark, up to 24 hours. But the number of people who really benefit, who still have salvageable tissue, becomes less and less. At 24 hours, they're less than 2%. So less than 2 people out of 100 will still have tissue in the brain that we can save. And most people will have infarcted completely within 6 hours. So time is really critical, and we need to really work like these pit stops, where they can change 4 tires, refuel the car, and do minor repairs and wipe the screen within less than 1 minute. That's amazing, and we all need to work together to make that happen. You need to call 000, and we in the hospital need to be really fast to do that. So let's talk lastly about what I think doesn't lead to much value. There is a doctor, I believe in Florida, who injects etanercept in the paraspinal tissue, then puts people into a chair with their head down so that it sinks down into the brain, supposedly, and charges them $6,000 or something. And had great success with that. I looked at his webpage, and you can Google him and find him there. The first patient he presented there, I'm almost certain, did have a stroke, but the symptoms she had had nothing to do with that stroke. She had, in my opinion, a psychological speech disturbance which immediately resolved after receiving this treatment, and certainly is not a miracle cure in my opinion. All the patients that I have known who went to that treatment did not have a substantial improvement in their outcome. And there is no randomized controlled trial that would show this treatment has any benefits to any patient. It's just very costly. And unfortunately, there's always people in every profession, including doctors, who prey on those people who are desperate to get improvement and have a better outcome with unproven therapy, who they mostly sell to an insane amount of money. And so from this perspective, there are a few things which I would urge people to not do unless they have a lot of money to waste. From my perspective, if something really works well, it will take off worldwide. Everyone will do it. Everyone will offer this treatment because it's successful, and it will find mainstay treatment in every hospital. If something is rarely done and a niche treatment in only highly specialized centers, then it usually doesn't work that well. All right, I think that is the end of my talk. I just want to stress again, stroke is an absolute emergency. Don't waste time. Time is brain. Call 000, come to a hospital. Thank you very much. Any questions?